Perfect. You're watching the Daily Report, 31 minutes past the hour. We thank you for staying with us right here on TV 47. My name is George Maringa. As I had informed you earlier, we have our guest tonight, who is none other than Principal Secretary for Public Health and Professional Standards in the Ministry of Health. That is Mary Muthoni CBS, HSC. I got those titles right?
Thank you.
Okay,
yes,
karibu sana. And of course,
so
earlier on, our top story actually involved, of course, what's going on in the country, especially touching on matters your docket. I'd like to give you an opportunity to respond to, the queries and the issues that the unions raise with that ultimatum for the strike notice.
Okay, yes, I've seen the story, and I want to state here that human resources for health is one of the critical agenda that we have as a government and as a ministry. Therefore, we are really thinking about them in terms of their vulnerability, if there is any. However, this is a conversation that is ongoing, and I think I wouldn't wish to really preempt on TV today, because I know my boss equally is in it behind the scenes, and it would be good to give a chance for dialogue, so that should there be challenges, then we can know how to solve them. Otherwise, confrontations may not be the very best in decision and solving of solutions. The alternative dispute resolutions always work and always carry the day. Therefore, I would really plead that we allow discussions that may be led by my boss to continue, so that we can see how to solve any challenges that we have. Okay.
I did see over the weekend, a few days ago, you went to visit Dr. Davji. How is he faring? What did you talk about?
He's doing well. You see, we are not enemies, and these are our brothers, they are our sisters. We talk, we call each other. And in fact, even when I was sitting here, I have talked to a few of them. However, when there are issues, then they need to be put on the table so that they can be solved. And I am confident that from the top, we are going to handle. Yes. We
will have a conversation after you handle.
So I will, yes. We can have a conversation when the ice is broken. I would not want to really preempt what could be going on or what my boss could be discussing. Yeah.
Brilliant. You've had quite a busy day. Earlier, you spent the day in Marsabit County. Talk to us about, initiatives like that especially involve, the international community as well. What exactly took you to Marsabit today?
SDG 17 talks about partnerships. And we as individuals and as institutions, either government institutions or private sector institutions, collaboration is the way. And this is just one of collaboration in terms of nutritional value and having the communities embrace other ways and means of getting food. Marsabit has more of pastoralist communities, but what we are seeing right now through the support of our partners, we have embraced even farming. So we have seen mothers, we have seen women, we have seen elderly in the communities really putting together kitchen gardens that are of nutritional value to their children. Remember, in the year 2020, 2021, there was a very huge drought that really swept off almost 70% of their livestock. And if you look at children, they got malnourished because of lack of nutrition elements. If your cow has died and where you used to get the milk to give the child is no longer there, therefore we had to really train them on other alternative ways and means of getting the same nutrition, express breastfeeding, and equally vitamins from the farm and other plants. So that's what took me to Marsabit, because we had a project which is multi-sectoral, and it is collaborated with UNICEF, the Ministry of Health, and Ministry of Agriculture.
Okay, brilliant. So, of course, being PS for Public Health and Professional Standards, the issue at the center of discussion right now is the transition from NHIF to SHIF, the Social Health Insurance Fund. First of all, where are we on the regulations? Because you appeared before the Committee of Parliament and you presented your ideas. Where are we so far as a country?
Well, we have already taken the regulations for comments from stakeholders, and that is why you also saw us with the Parliament, the Health Committee, the Delegated Committee, and this is basically to give the proposal so that they can have some input of the same, which is a requirement of the law. Right now, the regulations have already been forwarded to the AG for concurrence and publication. Regulations basically is a guide on how we shall implement that which we have already come up with and from the law. Therefore, it is important for the AG to also have a concurrence, and then the publication will follow. That is how far we have gone. And we are looking forward to ensuring that this is a success. Because once it is the publication is done, we will go straight on to registration of individuals. And this is going to take place between this month and the month of June. And thereafter, then we will see people really accessing the benefits of social health insurance. I don't know if you want us to go straight into what social health insurance means, because it is very important for Kenyans to really understand what is this social health insurance, which we used to call NHIF, the National Hospital Insurance Fund. First and foremost, we have 4 acts. We have the Social Health Insurance Act of 2023. We have the Digital Health Act. We have the Facility Improvement Fund Act of 2023 equally, and the Primary Care Act. But let me concentrate more on the Social Health Insurance Act. The changes that are there, one, we have 3 funds that have been introduced, as opposed with what we used to have, just a card where people used to pay 500 shillings, and that is the only fund that used to be there. So we have 3 funds. One is called the Primary Care Fund, which is inside the social health insurance. The Primary Care Fund is basically to take care of the local health facilities, what we call the dispensaries, the health centers, take care of them, because the level 2 and 3, 1, 2, and 3, people will not be paying the 20 bobs that they used to pay, the 50 bob they used to pay, they will no longer pay. It is publicly funded, and we shall, everybody is going to access these facilities without paying a dime. Then you move to the Social Health Insurance Fund, which is now, we are calling the NHIF. We used to call the NHIF. In the social health insurance, we will be paying 300 shillings, a minimum of 300 shillings. And no, somebody like me who is salaried per my household, then I will have to pay 2.75 of my gross salary. And this will help to also cater for other people who are not able to pay for themselves, probably even in my own family. Right now, if you look at the number of WhatsApp groups that we have, because somebody wants to go to India, another person wants to do an operation. So this social health card will be open for all at 300 shillings. And you may want to ask, what about the person who cannot afford the 300 shillings? Because we have them in our society. We already have a testing tool which will be used to actually tell whether you can afford 300 or you may not afford 300. If you cannot afford 300, then the government will pay for you. The indigents and vulnerable groups will be paid for by the government. Then we move to something else very interesting. Right now, what is happening with NHIF is you go to hospital, registration is maybe 1,000 shillings, and we get it from the card. By the time you're done with registration, your card is depleted. and you cannot access the services. So you're forced to go out, buy yourself drugs, or maybe even get other services from outside the health facility. But what we are saying is we have another fund of emergency, critical illness, and chronic illness. If you look at some of our facilities, they are near a road, and with the many borders that we have, there are so many accidents that happen, and it's an emergency. And sometimes you're taken to the health facility that is near there, and you're told you do not have either your NHIF card or you do not have something, you know. Therefore, with the emergency fund and critical illness, then you will be able to be treated. And the health facility can claim later that we treated this person, it was an emergency, and this is the kind of emergency. Again, issues dialysis. So many people, it's expensive.
Very expensive.
So you deplete per session. Issues cancer, very expensive. So you deplete your social health card, then we can plow into the fund, the kitty, which is for chronic illness, emergencies, and critical illness, and this person will be treated. Therefore, issues of WhatsApp groups will be an issue of the past, because everybody is going to be covered in the country. And just like I said, what we want in this country is an accessible, quality healthcare, and available at the same time, and affordability. Accessible in the sense that you can go to any health facility and get treated. People walk for long distances looking for just one service, whereas there is a private facility which is just next to your household, or there is a religious-based health facility and it's just next to your household. So what we have done is to do an assessment of all the levels of hospitals in this country, whichever whether it is public, private, or faith-based, so that we are able to do what we are calling the primary care network, mapping out the type of facilities that are near you. And with the help of community health promoters, you will be able to be directed to the right health facility that you require for whatever service that you want. And this is really going to help us so much. That takes me now to my next point. The other act that we have is the Digital Health Act.
Okay.
And I have said this before in many places, that when I was growing up, my mother had a very special exercise book. And you know, we were many, so she had so many of them tucked in a wardrobe somewhere, you know. And every time you got sick, you had to produce this exercise book. Why are we not doing the interrelatability of data? So that if you are referred from a certain health facility, then whichever other health facility that you go to, you will find your information with the health staff who is going to be serving you. And this interrelatability will help us even in our referral system, right from the grassroots with the community health promoters who are doing very basic roles at the grassroots, and then going to the lowest of the levels in the hospitals, and up to level 6, where you find specialized healthcare and maybe sophisticated machines, that equipment that is supposed to treat you. Then we have the other act, which is the Facility Improvement Fund, Act of 2023. Now, very interesting. Sometimes we find during budgetary allocation, we keep shifting one budget from one vote to another. This is going to be a thing of the past, because at the counties, the collected money at the facilities will be plowed back and will not be reallocated for maybe roads, environment, or any other. And the most interesting thing also is in terms of running the lowest of the facilities, we also will have introduced a way that the community is involved. in the committees that are in the health facilities, that you have a faith-based person, you have maybe private sector, and people from that community who will be the chair, the secretary, and all that. So you will have an opportunity to demand that this money is meant for equipment, will not be reallocated to go and buy a tractor. This money meant to employ staff will not be reallocated to go and buy something else. So whatever is collected in these facilities will be plowed back for the same.
And the disbursement will be in time?
In time.
Okay.
And then we have the Primary Care Act of 2023 that is recognizing the role played by the community health promoters. Initially, community health promoters used to be volunteers, but right now there's a change. We have community health promoters who are being given a stipend, and we have already started paying them. A stipend of 2,500 from the national government and a stipend of 2,500 from the county government. And this is a game changer because...
Since Madam PS, you're talking about it, you actually have a story on that, the CHPs.
Okay.
Let's take a look at it because it is a sigh of relief for the community health promoters as the government is set to start disbursement of their stipends early next week. Deputy President Rigathi Gachagua has assured the community health promoters, the CHPs, that the government has already released their money. Gachagua was speaking during the commissioning of the Mother and Child Unit at Nyahururu County Referral Hospital in Laikipia County.
Hii ni program ya serikali ya William Ruto na serikali ya Governor Irungu. Serikali kuu imewapatia hii kits na kila kitu. Tumesikizana, governor watawalipa 2,500 kila mwezi na sisi 2,500. Yetu governor pande yetu iko tayari. Next week utapata pesa yenu kutoka pande yetu. Na wewe governor, na wewe utayarishe yako uwapatie. Washikanishe, wasukume mambo yao.
Sisi kwa sababu tumefanya haya, nawe utusaidie na ukiagiza kwa sababu cabinet secretary yuko hapa. Tusaidiane now that we want to give a facility ya hii hospitali. Tumalize kwa sababu sasa tukiwa na maternity ward mzuri, tuko na men's ward. Men's ward wazee tunamtengenezea men's ward ingine kwa sababu ile sasa ile iko pale.
Absolutely, that is regarding the CHPs, Madam PS, that you were talking about. It seems to be a sigh of relief for them, is it?
Oh yeah, it is, and because this is a very good program that is going to help the societies, the communities. When we talk about people who do not leave their homes because the health facilities are so far, and the only thing that they require is to be taken blood pressure, checked blood pressure, or even blood sugar, or even a reminder on immunization for your children. This is the work that the CHPs are doing in the communities. For sometimes we are even walking patients, and each community health promoter is assigned 100 households. And averagely in Kenya, a household has about 5 people. So that's like 500 people per month. You can basically meet them, even in church, in the marketplaces, or even in their own homes. And the one thing that they'll train them is on nutrition. Stop eating this lifestyle, getting lifestyle diseases because of because of diet. They will also take their BP, the blood pressure, blood sugar. Most people may have blood sugar or blood pressure and they do not know. So they have the kits and they have the equipment to do that. Again, issues of public health. Public health, clearing of your bushes. Having a latrine is very important. Like where I'm coming from, I don't want to go there, you see? So having a latrine is a mandatory thing in this day and age. And reminding them that it is important to also wash their hands. Have clean and safe water in your household. So 3 things, personal hygiene, cleaning of your hands. Remember during COVID, all of us were madly in love with water and cleaning of the hands. What happened? We dropped the ball. And this is the high time to pick it up. And especially with issues of climate change all over. Then issues of environmental health again, reminding them that it is important that they plant trees, and trees are good because of the quality of air that we require to breathe, avoidance of common ailments, diseases like asthma, respiratory diseases that may affect us because of climate change. So reminding them on things like that, and clean water.
All right. Drinking
boiled and clean water, both for your use and also for kitchen use.
On the issue of CHPs, Madam PS, there are reports that the national government wants to take them from the county government because they're supposed to be shared. They are, they are supposed to be shared between the two levels of government. Is the national government grabbing them from the counties?
We don't have plans to do that.
Okay.
Not at all. And we are working very well with the county governments, for your information. By paying them, really, it's simply because we didn't have the bill had not been signed. And to this, I have seen His Excellency has already signed the grants bill.
Yes,
so really,
yes.
So we have now a structure on how to channel funds to the counties, and that is what was missing. So we have no obligation whatsoever to take away something that is already in the law.
Okay.
And for us, our work is policy and training. So we will train the CHPs on whatever, and we already have a training manual on how they need to go to the households and how they need to carry themselves, and on every other aspect. And we equally have trained them, we have kitted them, and we have already started disbursement of the funds, whereby the county government is supposed to do their bit and we are supposed to do our bits. The rest are administrative issues, really, which we always sit down with the county governments and agree upon. So nobody is taking up on the roles. And the CHPs, right now, we have also distributed the smartphones that they're supposed to collect data with. And with the dashboard, with the electronic gadget, we are able to see how many households they have visited at any given time. We are equally able to see some of the issues, the emerging and re-emerging issues that are at the grassroots. Because it's very important for also our planning, for policy making, surveillance of common ailments, diseases that are at the bottom of the pyramid. You know, if we look at where I was today, Marsabit, the influx of refugees really is on high from Ethiopia, the Ethiopia border in Moyale. So you're likely to find that in our country we are getting people with polio at the age of 7 years, which is an abnormality, really. So when we are giving oral vaccinations, we actually extend to even 15 years. And it is because some of the countries that are near us, maybe borders of Garissa, when we have them coming to our country, then some people may not be vaccinated, and that affects a lot. Cholera issues, you know, if there is emergence of public health events that is abnormal, then the CHPs are able to raise the warning, and we are equally able to respond in good time. And this goes hand in hand with the skilled force that we have, the surveillance department in the Ministry of Health. They are able to go to the ground and work closely with the teams, the health teams that are at the county level. Counties, their work is implementation. Our work is policy and training.
Well, going back to the new system that will be moving to the Social Health Insurance Fund, what has been done? Because you speak about the regulations, you know, what is going through the Attorney General and all that in matters policy, but what has been done specifically to test the system for mass transition to the new scheme, in terms of sort of feasibility test and testing it on the masses?
You see, once we are done with the regulations, there'll be a rollout for registration for everybody, which will take about 3 months. And this will give us time also. If there are any anomalies that are there, we will be able to correct in the process of the registration. And Remember, I talked about the digital health that we have, which is going to have interrelatability of data from one health facility to the other. This will also help us to interconnect the issues that are in social health insurance, so that anybody who is going to hospital, when you key in your data or your ID, then everything else, your age, it comes up, it pops up, and what you have been treated for before. So this is going to be an interesting time, and also with the digital superhighway, health digital superhighway, digitization of every other facility that we have. So we have time in whatever area that we may see that it is not really working for us, and we have time to equally have input and ensure that we correct in due time.
Okay. The payment of the contributions and access to healthcare under the scheme will commence on July 1st and not in March, as had been anticipated. Why is that?
What we are doing right now is registration, once the publication is done. And registration of individuals may take a while, because you have to move from household to household, knowing how many households or people you have who are going to be taken care of by the 2.75. Remember, somebody like who is 25 years, that's a household on its own.
Okay.
However, if you do not have funds, or if you're not employed, then you might be forced to register yourself as an indigent. If you pass the test of an indigent, then the government is going to pay for you. So all those processes are going to take place in due course. And meanwhile, at the, in the back scene, we will be working on actualizing the benefits from the 1st of July.
Okay, absolutely. And talking about actualizing of benefits, let's take a short breather. When we come back, we continue this conversation with PS Mary Muthoni, the Principal Secretary for Public Health and Professional Standards in the Ministry of Health. I can see your questions are coming, as well as that is on our SMS line. Please start with your name, where you're watching us from, as well as your question or comment to Madam PS on X at TV47 News, at Muthoni Kenya.
Muthoni Kenya.
You can post directly at George Maringa _ use the hashtag Daily Report. We are back in a few minutes. Do stay with us.
Na safari hii katika Mfahamu Kiongozi tutakuletea viongozi aina mbalimbali.
Nikuwe na Nisani kama 10 na pia nikuwe menua minibus. Minibus niko niwa.
Kushinda unaangalia simu ya mzee, soma Biblia ama ingia kwa washroom ujisugue mpaka nimetoa hii.
I don't know whether any of my children would want to get into the political field. Sijajua bado.
Kila Alhamisi saa 1:30 kuendelea.
Join us on a journey through the concrete jungles and rising skylines, where every beam, every nail tells a story of progress and vision.
In every aspect of life, you know, you have to look at several dynamics.
From groundbreaking,
Nowadays with the tech, you can check on different websites or you check online and you can see some inspiration. So at least that one would be a direction already. I'll know like what kind of style you're going for.
to finishing touches, witness the dedication of the hard-working teams who bring these ambitious dreams to reality. The Realtor, Tuesdays at 6:30 p.m.
Welcome back. You're watching the Daily Report on our segment Power and Politics every Monday. Tonight we talk matters health, because remember, health is wealth. And my guest is still here in studio, Mary Muthoni CBS, the PS for Public Health and Professional Standards in the Ministry of Health. Madam PS, thank you for staying with us.
Thank you.
Now, we're still on, when you look at the SHIF as you talk about it, it sounds, good in envisioning, how the government is going to ensure accessibility of health to everybody. So for a Kenyan who, of course, is watching us and wondering, so does that mean that when I walk into a hospital, I shall not be able to pay any fees? What exactly should they expect? Because at the end of the day, it will involve them accessing healthcare services.
Thank you. That's exactly what we are saying.
Okay.
Equitability. Health insurance for everybody in the country. Whether you're a mama mboga or you are employed like myself and yourself. For myself who is employed, my salary, my gross will be attached 2.75 of what I earn to contribute to the social health insurance. The mama mboga down there, if you have your 300, other than the 500 they used to pay, anytime she has cut herself with the knife, cutting skuma wiki, she can walk into any health facility and get treated without necessarily many issues. She can walk into the facility, and once treated, you also get drugs. This is what we are covering. Because many a times is when people have suffered. They go to a facility, we do not have human resources. And remember when I was explaining about the laws, we said that part of the money that is collected in those facilities using the Facility Improvement Act will be plowed back to take care of these issues. Human resources for health, equipment in the health facilities, and equally infrastructure in the health facilities. So with this social health card, it will only start at the level 4 hospital, where you need specialized care, possibly. Maybe you have broken your leg, or you need to be operated, you need a neurosurgeon, you need a gyna, the specialized care that is required. But at the lowest level, we will have the publicly funded through the primary care fund, which will take care of level 2 and level 3. When I talk about levels, I want to break it down, because it may not mean a thing to a common mwananchi. I'm talking about the hospitals we call dispensaries. Okay? Dispensaries which are next to our houses. So you will be walking in there and you will not be paying. Why? The government is moving away from more curative to preventive and promotive. We want everybody to take care of their minor ailments at the household, at home. If the CHP can treat you, maybe your child has fever, and we are able to give you a tablet and you don't need to go to hospital. If you need to just be told, yes, you have blood sugar, or you do not have blood sugar, can you go and see this specialized doctor or a staff in a health facility? So if we are able to reduce some of the preventable diseases in our household, we will not even have those queues we have in the health facilities. Long queues. You go in the morning and you leave in the evening, just waiting to see one health worker. Issues like cholera. As a country, we are not supposed to be discussing a disease called cholera because it is preventable. Issues, vector-borne diseases, malaria. You just need to sleep under a net and clear your bushes outside your homestead. And drain the water. And drain the water. Stagnant water. Stagnant water. It is as simple as that. Taking care of ourselves. And that's why we are saying, afya yako, jukumu lako. Before we even go to the facilities, then have we cleared what needs to be done at our level? At the same time, infrastructure improvement is important. In the sense that if you go to some of the places, you will find that a mother is giving birth in an open
area,
which is very demeaning, really. So when we talk about infrastructure improvement, we want to give dignity even to mothers. We want to give dignity to a mother who is lactating, that a health facility has space for women who are lactating, where they can breastfeed their children when they come for immunization or when they come for any other help that they are in the hospital. Again, equipment, the right equipment for the right job. If you move to our hospitals today, we have very archaic equipment, so to speak.
Broken wheelchairs, stretchers.
Most of them are broken down, probably.
Beds,
you know. So improving the equipment in our hospitals, going by the levels. And that is why the assessment of levels was for all the health facilities in this country, whether it is public, private, or faith-based. Because we do not want people to be going long kilometers, taking long hours on the road looking for just one facility when you have another one similar to what you're looking for next to your household. Therefore, equipping of the hospitals will be across board, so that it can help anybody who comes from that primary care network or that mapping of the facilities that is within your reach.
Yeah, because sometimes this country has been faulted for ignorance, if you could call it, in terms of spreading information and, you know, public awareness, if you could call it, especially to the masses. How are you perhaps curbing and ensuring that the public is absolutely aware of this great, if you could call it, health revolution that is coming, so that they are even aware of their entitlements? For instance, when you talked about when funds are allocated to, say, buying beds or equipment in a hospital, one can question and say, indeed, stop, you know, going for trips, stop earning per diem, get us beds.
Remember, partnership is key. Yes. And we are partnering with even the media to help us pass this message. Really, when there are challenges, 95% in the Ministry of Health is a good thing. There are good things that are happening there. But probably we have not been able to reach out to the masses, and that is why we are reaching out to you. That's why I'm here tonight, so that we are able to pass the message together. We also have the group, the CHP.
Yes.
The CHPs will be passing these messages to the households. When they go to visit them, they will have promotional materials that will help them guide the teams, the people on the ground on what they are required to do and the information that is supposed to reach out to them. We have our health promotion team in the ministry and equally at the county governments. The connection and collaboration with our county governments is really helping us a great deal. Because when we go for public barazas, when there's a chief's baraza, we have information and we have somebody who is giving more information on the ground. So we have strategies on how to reach the people, and we have already started doing that. Very soon, more and more people will embrace what we are already doing because the information will be there. The church is equally good space that we need to pass information, because collaboration with religious institutions is also very good in terms of spreading good news. Yes. And if we talk about things like drugs and substance, you know, something which is very rampant, even in our own spaces. Yes. Therefore, teachings and having groupings that will train the people, and also telling them any other information that is happening in the Ministry of Health. Yeah, absolutely. You know, we talk about spreading of information and everything else. I wonder, there has been 2 international conglomerates who have won, you know, the funding model of this specific social health insurance fund would hurt the Kenya's expenditure model. I wonder whether you would have any response to that, specifically, you know, Citibank Group and Standard Group.
Standard Bank Group, yeah.
I think let's break it down.
Yes.
If I tell you that this is 500 and this is 300, yes, why do you want to insist that 300 is more than 500? Mm-hmm. Okay? And I have said again and again, it is the wrong time for us to politicize matters health in this country. Mm-hmm. Therefore, it would be important to first we internalize and understand. And from the media point of view, we urge you that you are the people to go and tell the people the good things that are happening, irrespective of the many myths that may come to play. If we have the benefits to the people, then the better for all of us. Because if I am the one who is being deducted so that you can get helped, or my sister, my brother can get helped, where is the problem? At the end of the day, if I do not do that, then I will still go back to my pocket to maybe give the 20,000 that is required for X-ray, maybe give 10,000, another 10,000. At the end of the day, you'll use a lot of money vis-a-vis contributing to the social health insurance that may help the people. Okay. And the government, again, the indigents, the vulnerable groups will not be pushed to get to pay that which they do not have. That is why we have the means testing, instrument to get to know who can pay from our society and who may not pay.
How optimistic?
This is like a harambe.
Yes.
And we want to put money together to help all of us on matters health.
Yeah. How optimistic are you that this SHIF, the Social Health Insurance Fund, will be onboarded as you perhaps as a ministry envision it would be, in terms of, reception by Kenyans and practicability of it all, looking at all the organs, national government and as well as county governments and partners?
Because we already have a plan, and what we are doing is implementing the plan. Okay. And we will be guided by the documents that we have already given out. Yeah. Okay, brilliant.
So will there be a new registration of NHIF members to the Social Health Insurance Fund?
Everybody is going to register.
Afresh.
Remember, we are moving away from correcting that which has not been working to something new that we are introducing. But again, what we have done is, it's like having an added point to an already existing document. So we have NHIF, we have tried, we have tested it. It has not worked perfectly. Therefore, we have social health insurance. And with the new regulations and guidelines that we have, it would be important that we now register people afresh. We have had stories of even people who are operated in hospitals and they don't exist. So why don't we go back and register afresh everybody who we can see and know that this is a person who exists, so that we don't go back to those horror stories of people going to health facilities and maybe using somebody else's card, admitting themselves and getting out, coming to get themselves out of the hospital, whereas you never even slept even a single night in that hospital. But all said and done, I think public health activities are also going to reduce the number of activities and queues that are in the hospitals today. And that is what we are emphasizing, that we want to move away from more curative to preventive and promotive. Even if we are going to have the insurance card, you can have that insurance card and you don't get sick. So you don't need to go to hospital. And we pray that more and more people do not get ill every day, because economically it is not good for us. Financially it is equally not good for us. And mentally it is also not good for us. Physically it is not good. So we would pray that we embrace more public health activities in our homes, at our workplace, to ensure that that ailments that do not require to be taken to a health facility are cleared within our spaces. that is why we are also coming up with a public health day.
Okay.
A public health day which is going to take place once in a month. One day every month, everybody to come out and deal with issues, personal hygiene. That is a day that I would want to see a water point for cleaning our hands, even when we are coming to the station,
Yes.
at the gate, yes, where the watchman is, and any other space within the premises. Our school-going children, again, water spaces where they can clean their hands, giving them basic things like handkerchiefs, you know, things that you never think are so important. And again, also issues to do with environmental health. Environmental health is very key because the air that we inhale cause some diseases that you may not imagine. Diseases like asthma, respiratory diseases, complications that we can prevent. And water.
Absolutely. Back to the issue of registering. You know, do you not envision perhaps challenges in registering people afresh, and what timeline would you be looking at?
We are talking about 3 months,
Okay.
but this is going to be continual.
All right.
It does not mean that after 3 months we will stop registration. Registration will continue because this is a continuous process. People will continue giving birth, and children are going to continue getting, we are going to continue getting biometrics from children from the age of 7 years. Remember, why the age of 7 years? I can see that question on your face. You're about to ask.
Yes.
Scientifically, that is when a human being features are formed at the age of 7 years. So it is good to take biometrics for children at that particular age. And we will have many more children getting to 7 years every other year. So registration will be continuous, really. And Rome was never built in a day. There is room for improvement in everything. We already have gotten feedback from the field, from stakeholders, from parliament, members of parliament, from other groupings, private sector, and other teams from the Ministry of Health. Therefore, whatever the feedback they give us is what we are trying to input, or we have already input for publication.
Okay.
But should there be a challenge, anything that is made by man can also be corrected by man. It is only natural calamities that you cannot stop. You cannot stop the sun, you cannot stop the moon, you cannot stop the rain. But if it is a document that we have written, we are bound to relook into it as we progress, so that we can do any rectification, should there be any. But so far, so good. I'm convinced that once we start, there's not going to be a setback.
Is it true that NHIF staff will reapply for their jobs under SHIF?
These are administrative issues, really. And I think it would be wrong to preempt everything that has not even happened. And if communication has not been done to them, why worry? I am not sure. I have not seen any communique that
and there are no intentions of such
that has requested them to reapply. So should there be such a communique, then I will come here and we discuss.
Okay, absolutely. Okoich Kiplagat on X asks, what is the status / plan for the absorption of the healthcare professionals who were contracted under COVID-19 response project?
Those are issues, human resources for health, and they are lumped up into what you have seen today. And quite a number of issues that behind the scenes we are discussing with PSC, discussing with the county governments for a possible absorption. However, I think it is important that we give it time so that conversations can be concluded and we do not have confrontations in future. I know we have a contract that is ending in May from the national government, and we are on top of it.
Justus Muvenge asks, ask Madam PS why they are exporting nurses abroad at a time when the country is grappling with the shortage of nurses.
Really, We are not reinventing the wheel.
Uh-huh.
Export of labor has been there from time immemorial. Currently, Kenya exports about 3,000 workforce across the globe. So it's nothing new that we are doing. Okay. All we have done is to structure, to have a government-to-government engagement for people to be comfortable in wherever areas that they have gone. And especially, sometimes you find very young people have gone to new countries. They do not know their way around. And maybe even their visa, they miss on work permits or small, minor things. It would be important that when a government knows who is out of the country, where they are employed, who has employed them, how much they are earning, and any other issue. Should there be a diplomatic issue, row, that would come, then the government has the mandate to come through and protect its citizens. So we have really not done anything new that has not been done before.
Okay.
Secondly, the production of human resources for health is at its moment. Because KMTC alone, if you look at data in the last 3 years, coming from a mere 7,000 graduates to about 22,000 graduates. That is the highest number of graduates that we have in any institution in this country, not even Nairobi University or any other university. Therefore, that shows we have new human resources for health that are graduating every other year, and we need to fix them either locally or internationally. It is better when you take a job in the UK or US or Saudi, because we have orders for such spaces, and especially Saudi, where they require about 2,500 nurses, other than just staying at home. And this also helps us in terms of planning ahead, that we have a number of nurses who have gone abroad. Therefore, we may need to recruit or we need to train certain cadres that are really required into the market, both locally and abroad.
Okay.
And I am calling upon all the nurses that the jobs are there. Please go to NEA website, the National Employment Authority. Don't stay at home and say there are no jobs and you have not tried. Go and check whether the government has advertised jobs or for both local and abroad. And equally PSC, the Public Service Commission, it's posting jobs every other day. It would be important that we get out of our way. And I want to encourage the young people. Sometimes you need to wake up, dress up, and show up where the action is taking place. Because the mountain will never come to where you are. You have to go to where it is. Therefore, we have laid the ground for them. It is up to them to take up that which is on the table. And right now, we need 2,500 nurses for Saudi. Yes.
Of course, you sort of answered the question I was about to ask you. Growing up, we would hear people, say they have ambitions of becoming nurses, doctors. Yes. Is the field still as lucrative for, even the young ones watching and saying they still have ambitions of, joining the medical field? Is it still as inviting?
Definitely it is. Because if you look at the admissions that we are having at KMTC, we advertised last time and we only needed about 12,000 as newcomers. But we got applications for over 40,000. Therefore, that shows how lucrative and how more and more people really want to get into the profession. And for us, it is to ensure that we have the right policies, we have the right tools to ensure that we train the right cadres for the masses. I'll give an example. When you look at the accidents that are happening on the roads, sometimes through motorcycles. Sometimes you're knocked by and right next there's a health facility that may not have a qualified staff to treat that kind of a person, even trauma, even as basic as mental health issues, which is which has become a big issue in our society today. Therefore, we will need to keep training these specialized cadres to ensure that we take care of the masses at whatever level.
Okay. Is the country's, healthcare system sufficiently equipped to allow the government to send out nurses?
In terms of employment?
Yes, yes.
We have said that we already are producing enough graduates every year. And this is to ensure that we absorb them locally, and the ones that are of maybe we have excess, we can send them abroad. And sometimes you don't have to force people to work either locally or abroad. It's a choice for a person.
Perhaps they're going...
So for us as government, we continue looking at the gaps. And when I started, I told you that we have already done an assessment of all the levels in our health facilities. So we know the gaps, we know what we need. What we are doing right now is costing. Because we can't just wake up one day and say, send 10,000 health workers, health workers to maybe West Pokot or to Mombasa. We are doing the costing to know how many we require in every health facility. How much will it cost the government? How much equipment do we require in a certain health facility? How much will it cost the government? Where there's no plan or structure, we are bound to fail. Okay. Now we have a plan, we have a structure. For us, it is to implement that which we have already done. Therefore, in due course, I will come and we discuss that aspect. And I'll give you even the figures and the time frames.
Because perhaps they could be going to look for better pay. Are you perhaps looking forward to standardizing and matching?
These are conversations that we can have every now and then, really, on improvement of pay for health workers, really. It's a conversation that is continuous. Since right now we are working on their CBS, then I'm sure that one will come up.
Madam PS, we are entering the home stretch because of time. We thank you for your wonderful time to be able to speak to Kenyans and of course clarify on the few issues. I want you to speak to Kenyans through that camera and speak to them especially on this issue of SHIF and perhaps your parting shot as well on matters health in this country.
I think for me, mambo ni matatu. We want to make our healthcare system and agenda to be available, accessible, and affordable to all Kenyans. And to Kenyans, they need to take matters health in their hands to ensure that they prevent themselves, they protect themselves, and they promote health activities that are supposed to they are supposed to have, so that we can prevent the minor ailments that we have in our societies and communities. And so to speak, we also need to avoid other aspects that can get us into poor health, issues to do with drugs and substance, issues to do with the drinking of alcohol, misuse. I'll call it misuse of drugs and substance. We need to take it down. We need to reduce in our communities, in our societies, so that we can build a healthy nation together. Afya yako ni jukumu lako.
So you say that we will match up sort of what we see in private hospitals, in our public hospitals very soon.
I think our public hospitals are not as bad as you may want to paint them.
Okay.
Really.
Not painting them, really.
We actually are at par with some of the private hospitals that you may want to mention. And that is why we want you, as a Kenyan, as a citizen, to allow you with the social health insurance, you can be able to go to any health facility and you will not be turned back. In the next few months, we will no longer have any Kenyan who will be turned away from any health facility because they do not have money.
Okay. Absolutely. Madam PS, Mary Muthoni, Principal Secretary for Public Health and Professional Standards in the Ministry of Health, speaking to us tonight on the Daily Report. We shall be looking forward to inviting you over and over again, even when the program is finally rolled out, to be able to look at how the implementation is going on. Thank you so much.
That's not the only program we have.
Of course.
We have many, many others. So I would want to also come and tell Kenyans more about public health.
Absolutely.
And how we can utilize that space to avoid many events, public health events that are unwarranted.
Okay. And tonight you wanted to deal with SHIF, and then now we will also discuss more in the days to come. Thank you so much, Madam Piers.
Thank you. Thank you for having me.
Brilliant, brilliant. Thank you so much for coming as well. My name is George Maringa. Thanking you so much for your splendid company right here on the Daily Report. Remember, every Monday we bring you powerful and important conversations right here on TV47, your home, the home of untold stories. I'll see you tomorrow on the People's Court. It's a good night from Nairobi.
Na safari hii katika Mfahamu Kiongozi tutakuletea viongozi aina mbalimbali.
Nikuwe na nisani kama 10 na pia nikuwe menua minibus.